You. Teacher of my daughter, who is a nephrologist now.
Thank you. Thank you for the very kind introduction by the chairpersons, respected chairpersons, and my dear colleagues. It was said that my topic is a continuation of the previous one. It's not a continuation, it's the next stage of the previous one. So I am not talking about infections in diabetes, I am talking about what infection does in diabetes and how it causes sepsis and how should we manage that sepsis, what is different in diabetics versus non-diabetics. So I want to stick to that specific area. I have no conflict of interest to declare. I was asked to put this slide because they said that if audience wants to take photographs, you are most welcome. Knowledge is not my prerogative. It's a knowledge forum. You are most welcome. So what is the definition of sepsis? According to the third international consensus definition of sepsis, is now defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So not just the presence of infection, but you must have a dysregulated host response. The human being must respond dysregulated to the infection. That produces an organ dysfunction and that can cause also septic shock. So whole of ID, infectious disease medicine, has shifted from looking at the bacteria to looking at the host, and the response of the host is what causes damage and organ dysfunction. So in this talk, we will go through the clinical presentation in diabetes. Remember, I am only differentiating diabetes from non-diabetes sepsis. So what is different in the clinical presentation? Are some complications common? What are the management issues? How do we control the sugars in sepsis, in diabetes? What's the prognosis and what's the follow-up? So I think Dr. Bhavatharini has made my life easy by explaining all this to you about the immune dysfunction and the complications of diabetes, making treatment of diabetes harder in diabetic patients. Now it's a double whammy. There is a diabetes, there is a sepsis. In both you have an inflammation and an immune suppression. Remember, sepsis has two phases. There is an inflammatory phase, there is an immune paralysis phase. So I don't want to go through this busy slide, but you can see that in both diabetes and sepsis, both the things are exaggerated. There's inflammation is also more, the immune suppression is also more. That's what leads to poorer outcome. So let's start from the beginning. We know that sepsis begins with the diagnosis. If you make a diagnosis, then you can treat. So what's different about the diagnosis? Is it difficult? Now, I will start with cases that I have seen because it's easier for me to talk about them. A 75-year-old uncontrolled diabetes and hypertension complained of upper abdominal pain since 2 days. As usual, everybody thinks upper abdominal pain is gastritis, so he took a pantoprazole, but he vomited and felt tired. He had no fever. When I examined him, the only thing that made me look up was the heart rate of 120 and the BP in a hypertensive being 100/60. There was tenderness in the epigastrium. I forced him to get a TC-DC done. That's all I did. Asked him to do a total count and a differential count, and that showed a 29,000 total count at a differential of 90% neutrophils. Of course, I did an ECG because you're always worried about inferior wall MI in any diabetic complaining of upper abdominal pain. The CT abdomen that we did showed a huge gallbladder, and it was an acalculous cholecystitis. No fever, he was marching towards septic shock. Let me present one more case to you. Again, a 65-year-old diabetic with hypoxia, hypotension, cough for just 2 days. 1 day history of fever 4 days ago, not even now. Given antibiotics, felt better, but the X-ray showed bilateral pneumonia, mild abnormalities of the LFT, RFT, high total count, low platelets, BP dropped. Sepsis, septic shock. Mild fever, marched towards septic shock. The problem being elderly and diabetic. So what makes recognition difficult? The absence of a typical fever, the presence of vague symptoms, the fast progression. But always remember what saves us as doctors for making the right diagnosis is just examination of the pulse and BP, which we forget to do in many patients, and one simple investigation, which is the total count and the differential count. Time is tissue in sepsis. The more you delay, the more tissue is destroyed. So organ dysfunction is what predicts survival. So the SOFA score, which is the sequential organ failure assessment, is infection plus 2 SOFA score change makes it sepsis. So what are the organs that we are looking at? Respiration, coagulation, CNS, liver, renal, cardiovascular, and 10% mortality comes once you have a sepsis. So the most dreaded complication of sepsis is septic shock. So that's what you are worried in all your diabetic patients. Are they going into septic shock? Now let's look at this patient. He's a 56-year-old diabetic, 10 years duration, 1 week fever, vague abdominal pain, LFT and mild bilirubin raise, slight increase in alkaline phosphatase. Total count was decreased, ultrasound abdomen was asked. I can never forget this patient because I went for a late rounds in Manipal that day and he was sitting and eating when I saw him and I moved away. By 1 hour, my PG called me and said the patient has collapsed. I said I saw him eating. The BP had come down to 70/40. The ultrasound report came back from the ultrasound room as a liver abscess. Again, raised to shock. This turned out to be a Klebsiella liver abscess syndrome, which is caused by the hypermucoviscous strain of the Klebsiella, very well known to occur in diabetics. Multiple abscesses, very bad prognosis. The battle for sepsis is fought in the endothelium. So it is the glycocalyx of the endothelium which is injured in a chronic hyperglycemia that leads to organ damage. Septic shock has a mortality of 30 to 40%, common in diabetics. Large cohort studies have shown this, and like what Madam has told, immunity, poor vascular responses, comorbidities. So always monitor patients with diabetes for progression to shock or sudden deterioration. The basic principles of treatment of sepsis are the same. Whether you are a diabetic or a non-diabetic, all you want to do is to maintain that BP with either fluids or inotropes. You want to give your antibiotics and you want to do your supportive care. Now, where does it get difficult in diabetics? Because many of them have renal dysfunction. Madam was telling about emphysematous pyelonephritis. Gram-negative bacteremia is well known. More sepsis and shock. You can see the kidney on the right side showing the emphysematous gas in the kidney. And it's linked to better glycemic control. Renal failure is 1.5 times more common in diabetics, more severe, late recovery. And let's look at this. So you are there in the ER, a 70-year-old diabetic with UTI and oliguria, presents with septic shock, 80 millimeters systolic. The ER physician rushes fluids as per protocol. He's not done anything wrong. He's doing it as per protocol, 30 ml per kg as per surviving sepsis guidelines. In 2 hours, patient develops breathing difficulty and hypoxia. How do we manage this patient? Are fluids always safe? Cardiac dysfunction in sepsis, renal failure in sepsis, ARDS worsens. So we cannot follow every guideline for every patient. How do we manage this? In fact, it is known that large amounts of fluid that you give here can cause increased risk of death. One of the tests that we often do is called the furosemide stress test. All of us who work in the ICU give this. We give 1 shot of furosemide after adequate fluid. This is to test the tubular integrity. But this may be blunted in diabetics, so you really cannot judge whether this patient is going to open up or not after you give your furosemide. In diabetics, difficult to interpret. So what's the guidelines now? It's not protocolized, it is patient-centered. Look at your patient and change your protocol. Use dynamic variables. For the fluids, go clinical. Check for dyspnea, Krebs, hypoxia, JVP, IVC collapsibility, urine output monitoring, passive leg rating says. Finally, no one size fits all. So never treat a diabetic like you treat the non-diabetic, especially if they have renal dysfunction. Acute kidney disease is the one that comes between AKI and CKD. It's a bridge between that, and diabetes is a very strong risk factor for AKD after AKI. Progression to CKD is possible, as the graph shows here. There are many ways in which one can recover from AKI. Moving on to the cardiac dysfunction, which also contributes to septic shock, hypotension. Much more common in diabetics, much more. That is because of the IHD and also the microvascular disease that you have. You also have a global hypokinesia. You also have an RV dysfunction. Always send in diabetics with sepsis 1 TROP-I and 1 NT-proBNP because myocardial dysfunction is well known. and it is known that this impacts the patient's outcomes, because once you have a cardiac event, then you have a very poor prognosis in diabetes. Sepsis-induced cardiomyopathy has a huge impact on diabetes, and it is associated with higher mortality rates, and diabetes is an independent risk factor for worse myocardial strain and delayed recovery. So how do we manage? Now we said that we won't rush the fluids always, we'll go play it by ear. Earlier use of inotropes, start your noradrenaline, start whatever whatever you want earlier in diabetics rather than non-diabetics, and go with the clinical improvement. Also, we must know that the recovery from this cardiac dysfunction may not be immediate, so we have to follow up. Many patients with sepsis will be discharged with a BP of 100 by 70, but they may be hypertensive. When they come back, the cardiac function will recover, so follow-up is very important. Moving on to the CNS, we all know that septic encephalopathy is known. Many of our patients in ICU with diabetes with sepsis are unconscious or altered sensorium because of sepsis. It's much more common in diabetics. Severity is more, and if sugar, electrolytes, the usual suspects are all ruled out, then please remember it could be septic encephalopathy. Non-convulsive status is known. Many times we do the EEG in patients in our ICU to rule out a non-convulsive status. He's not having a convulsion, but EEG is showing abnormality, and cognitive recovery is late. Moving on to MAFLD, we know that sepsis-induced liver injury is known. It may be masked in diabetes because already he has MAFLD. Difficult to interpret SOFA scores will be there, and subtle signs of sepsis must be recognized to avoid missing this diagnosis. The one thing that stands out as an odd feature is that ARDS in sepsis in diabetes is actually lesser risk. We don't know why, but people with diabetes going into ARDS is less. Madam talked about skin and soft tissue infections. We all know about gangrene. We all know about necrotizing fasciitis, which are major sources of sepsis in diabetics. Why is it? That also she has explained about peripheral neuropathy, peripheral vascular disease, hyperglycemia, causing osteomyelitis and polymicrobial sepsis. Now the role of antibiotics. We finished about how we manage the BP. Now let's look at what do we do with the antibiotics in patients with diabetes. First of all, draw blood or relevant cultures like you would do in any non-diabetic. Start appropriate antibiotics, gram-positive, gram-negative. What is the organism you are thinking of, or it's a fungus? Think of that and start appropriate antibiotic. The 1 hour rule in sepsis is that the earlier you start your antibiotic, the lesser is the mortality. Every hour you delay in giving the antibiotic, the mortality increases by 10%. So that is why we have to start empirical antibiotics early. What differentiates a diabetic from a non-diabetic is a source controlled. Suppose you have a necrotizing fasciitis, your surgeon doesn't operate on him, then whatever antibiotics you give will not work. Similarly, you have an emphysematous pyelonephritis, you may have to do a DJ stenting to get out of the pus. You have a liver abscess, you may have to drain. You have a foot abscess, you may have to debride. So the source control is what is different in diabetics from non-diabetic. The role of steroids. Many times we give this sepsis dose of steroids, that is the hydrocortisone 50 milligrams IV 6th hourly. After we have finished all our 3 triple inotropes, we do this because it increases the vascular sensitivity to the inotropes. So that's why we give. But can we give it in diabetes? Yes, we can, because what are you more worried about? You're more worried about the BP or the sugar? The sugar we can control. The BP is crucial for the brain and the kidney and the heart. So we identify the bigger enemy and we give the steroids, monitoring the sugar. I want to bring your attention to an unusual link. Many times we think diabetic foot ulcer is there, but do you know the diabetic foot ulcer is associated with cardiac autonomic neuropathy in 43 to 66% of those who have. So remember, diabetes is not one complication. We have to look at the patient as a whole. So cardiac autonomic neuropathy is a big thing in diabetes. Look at this, 68-year-old diabetic hypertensive, 25 years duration, UTI, septic shock. He is in the ICU, you are thinking that he is recovering. Suddenly you hear from the postgraduate, he has arrested, cannot be revived. What happened? This is the sudden cardiac arrest that happens in diabetics because they have cardiac autonomic neuropathy. Now, this is the cause of sudden cardiac death, and that is why we are always scared of our diabetic patients when they have an infection. We are always worried, will they come out or not? there is a decreased heart rate variability, there is a resting tachycardia, which is the first sign of a cardiac autonomic neuropathy in diabetics, is a resting tachycardia. Plus, sepsis exacerbates gastroparesis. Remember, autonomic neuropathy, apart from cardiac, can make your sepsis patients vomit. Many times they vomit, their ileus tube aspirate comes out. That is because of the gastroparesis caused by both diabetes and sepsis. The bladder emptying is poor. So many times they have to be on a catheter. You can't say you'll remove the catheter because the bladder, if it doesn't empty, then it's going to be a source of infection. So the autonomic neuropathy not only makes diabetes difficult to manage because of the danger of sudden cardiac death, it also exacerbates the other things that we told, like gastroparesis and bladder. Investigations in sepsis and diabetes, we know that we do the biomarkers, we do the procalcitonin, it's not much affected. But when you have a CKD and diabetic nephropathy, your procalcitonin can be high even in the absence of an infection. Similarly, in diabetic foot ulcers, it can be high even in the absence of an infection. What do? You go with the other evidence, of infection. Don't rely only on the procal. The electrolyte problems in diabetes, we all know hyperkalemia and diabetes is because of CKD or type 4 RTA. Hyponatremia can be pseudo-hyponatremia because you got very high sugars, or an SADH. You got a bicarbonate which is high because of the acidosis from CKD or lactic acidosis. Hypoglycemia and renal dysfunction actually will make it worse. Now, sugar control in sepsis, diabetic patients and non-diabetic patients, this is the NICE sugar study, this shows that hyperglycemia is an independent factor for mortality in ICU, and this is the NICE sugar study which told us that we should have a target of 180 or less for lower mortality. The point is that you want it to be in a tight range. You want it to be within 140 to 180 according to the ADA. Avoid hypoglycemia and avoid fluctuations. We don't want glycemic variability. We don't want 100 and then 400, then again 100. That we don't want, because the glycemic variability is what causes mortality. Hypoglycemia is well known even in diabetics in sepsis, and that can increase the mortality. That's because of the poor nutrition, liver dysfunction, renal dysfunction, adrenal insufficiency, and the cytokines of sepsis, they only will utilize the glucose. So how to feed these patients? We are feeding through RT, continuous or intermittent. When to do the sugar? Always do before you feed, before the next feed, do the sugar. Factor in the duration of insulin that you're given. If you're giving a short-acting insulin, it's going to act for 6 hours. Your IST feed will come twice before that. Remember that. And the target is there. Insulin infusion is better to give if the sugars are high. Close monitoring is important. Never rely on a subcutaneous insulin in the presence of shock. Absorption is variable, and if you have a hypoglycemia, it is dangerous in comatose patients. Better to do an arterial or venous puncture and not a capillary glucose in the presence of shock, because it may be falsely low. The other drugs that we are giving are best avoided for the various reasons that I have written here. I am not going to explain that. Now, the role of antibiotic therapy, how long do we give? We give for bacteremia 7 days, but based on the sugar control or source control, you can prolong it. And what is the prognosis? Does it change in diabetes? Not all news is bad news. Many diabetic patients actually do well, and the mortality is not very high compared to non-diabetics. That is because we are managing them better. The follow-up is very important, because if you have a UTI more than 3 times, you don't want him to come back with septic shock. Please put him on prophylactic antibiotic. Diabetic foot, control the infection, give him proper shoes, avoid trauma. BP, look at it and check again. Diabetic medication will require adjustment, and sepsis leaves behind damage. So you can see the chart here which is showing you, compared to the normal person, the diabetic patient takes a longer time to recover the immune function. There are new horizons that have come up, that is the autonomic nervous system and the immune system link. They have shown that the cholinergic is an anti-inflammatory pathway, and many immune cells express adrenoreceptors. So noradrenaline has been somewhat put in the dock and says that it may actually increase your dysregulation of the immune system. And this is why other drugs have come in, like beta blockers. There is a review with the ivabradine, and also transcutaneous vagus stimulation is also known. Just to summarize, recognition of sepsis in diabetes is challenging because you have unusual presentations. Sepsis progresses fast and becomes more severe in diabetics. Organ dysfunction makes fluid management complicated. Autonomic dysfunction makes sepsis worse. Tight control is needed for good prognosis. You do not want glycemic variability, and follow-up is very important. Gaps in understanding, maybe we'll understand more with better targets. And most importantly, it's the alert clinician that saves life in diabetes and sepsis. Thank you all for a patient hearing.
Can we have the active applause, please?